record, share the screen, and get this show on the road. And how's that look? You guys see a big picture of a bladder? Got a couple head nods. Cool. Well, let's go ahead and knock this chapter out then. Here's your diagram of basically the ureters entering the bladder. You've got two ureters coming down. They enter on the bottom. This is called a trigone. I think that's about where we left off last time, which is a triangular shape at the bottom of the bladder, two holes being the ureter entering into the bladder, and the third hole being the urethra leaving the bladder. And that's pretty much it. This muscle right here does have a name, and I would like you to know it. Right there is called the detrusor muscle, D-E-T-R-U-S-O-R. And the detrusor muscle, I don't know if I can write that. We're going to give it a shot. Detrusor. That's acceptable. Okay. Not that R. That's terrible. Okay. Sorry. Detrusor muscle. It can actually contract a little bit to push that urine out. Mostly it's a gravity-fed system, but the detrusor muscle can squeeze just a little. As far as pushing, the urine out of your body, you're familiar already with, what is it? Transverse abdominis. The abdominal muscles that run this direction across the bottom of your abdomen, those can squeeze in as well, puts a little pressure on lower abdominal organs, and helps push that urine out of the bladder. And that's about it for that diagram. So urinary bladder, ureter, urethra, and that's about it. One of the things I really did like on that crash course video was it showed the internal urethral sphincter, which is difficult to see, and it had it kind of holding back that urine, and then an external urethral sphincter that you have voluntary control over, and how the internal one would kind of open up on its own. Urine would flow down and give you this terrible urge to, like, you must urinate right now, and that external sphincter can kind of hold on to that and wait, and so that was a really cool, that diagram alone is neat, because it's not something that I can really show you as well, I think. So trigone is just the three-sided shape made with those three holes, ureter, and urethra. And so two ureters come in, one urethra leaves to the outside world. The trigone is the site of most urinary tract infections, because up until this point, you're essentially operating in a sterile medium. All we've done is blood plasma and kidneys. There really should be essentially no bacteria in the kidneys, in your blood plasma, any of those places, in the ureter either. But where bacteria are is the outside world. And so, you might have heard, urine is sterile, which for the most part it really should be. But, as soon as it hits the interface between, the urethra and the outside world, it's fair game for bacteria. So, bacteria grow on the surface of your skin. So, they're right where the urethra is leaving the body. And so if for whatever reason you get, a bad type of bacteria, not like normal healthy bacteria that are on your skin all the time, but bad bacteria in the surface of that urethra, it can kind of climb the tube, if you will, cause an infection in that urinary tract, and then things are, I would assume, inflamed and painful and that kind of stuff when you're urinating, because I would assume that was what would happen when you get an infection just about anywhere, right? Then there's a detrusor muscle, which we already went through my sloppy handwriting with, which is the muscle layer of the bladder. It is smooth muscle, and it participates in urination, causes that contraction. So I would like you to know detrusor, and I'll throw a Quizlet flashcard over that guy. You guys have written what you want to write? Okay. I feel like I'm clicking too quickly, so, anyways, urethra is pretty straightforward. It is a hollow muscular tube. You guys have seen this design before with other, hollow tubes, but just a muscular tube. It's going to drain urine out of the body. There are two sphincters like you saw on the crash course video. There's the internal urethral sphincter and the external urethral sphincter. The internal urethral sphincter is basically right at the bladder, right at the bottom of that trigone, right when urine's leaving the bladder. is the internal urethral sphincter. This is involuntary. You don't have control over this no matter how badly you want to make it through that car trip without stopping. If the internal urethral sphincter opens, urine is going to start to drop out of the bladder, and you're going to be very uncomfortable, perhaps even to the point of pain, because there's pressure, there's gravity fed, hydraulic pressure against that external urethral sphincter, and that external urethral sphincter desperately wants to open, but with your brain, you are telling it, no, stay closed. I don't want to pee my pants right now. And so it keeps it contracted. And so then the external urethral sphincter is skeletal muscle, so it's under voluntary control, thank goodness. And you keep that contracted, and then when you kind of choose to relax it, which is a little weird when you think about how skeletal muscles work, but that's fine. When you choose to relax it, then urine can go ahead and leave the body. We don't really use our books, so don't worry about that. There are obvious differences between a female urethra and a male urethra, so this will make a difference for you future nurses who have to put in a catheter. You might be curious, like, well, why is the female catheter tubing this long and the male catheter tubing is much longer? Well, obviously, female urethra is a very, very short journey from the bladder to outside of the body, whereas the male urethra has to travel from the bladder past like the prostate gland, then out of the penis, and so there's like this whole long like trip for the male urethra, and so obviously they're gonna have much longer tubing. If you have to put a catheter in a male, you have to put a catheter in a female. So for all you future nurses, I guess be aware of that. But pretty logical. You don't have to memorize these numbers or anything. Just kind of get the very simple idea, right? That females have a shorter urethra than males, and that shouldn't be surprising. I don't think, but anyways. So let's talk about this ridiculous word. Why don't they call it urination? I don't know. The rest of the world calls it urination. Whatever. It's fine. Micturition. Micturition? What is that? Whatever. The process of emptying the bladder is micturition. If you have about 200 milliliters of urine or more, I'm trying to think, 100 milliliter graduated cylinder, if you're familiar with that in the lab, actually our beakers, the standard lab beaker is 250 milliliter, right? So actually my coffee cup is probably not a bad example of 200 to 250 milliliters. It's about the size of a beaker. So think a standard coffee cup, right? That's going to be about how much urine is in there. You hit about the 1/3 mark, 1/3 to 1/2. That's not a lot of fluid, but that's enough fluid to put pressure and gravity to stretch that bladder a little bit, hit those stretch receptors, and for them to tell the brain, we should go pee. It's not at a point of pain. It's not at a point of like you're going to urinate, in your pants or anything like that, but it's enough weight to get those stretch receptors to say, we could go now. So the bladder stretches under that weight. Sorry, I talk first and I look at my PowerPoint and I'm like, oh, well, I just said that. Okay. So the spinal cord does send a reflex, and that reflex goes to your internal urethral sphincter. And so it's sort of a strange thing to think that that's actually not processed in your brain, but your spine starts the process of urination, which is weird, right? So spinal cord in your back says, let's pee. And, when you're a toddler or a baby who's under the age of about 1.5, when that spinal cord says open up, it opens up internal, external, everything's out. They don't control that. So as desperately, as a father of 3, that I'm like, can we potty train at 8 months? Is that possible? Can we get done with diapers? Come on. No, you can't. It's a reflex, like if a doctor smacks your knee and your foot pops up, right? You can't fight that. So the internal urethral sphincter opens up with the input from your spinal cord, puts that pressure on the external urethral sphincter. You stop that urine flow, but also get that sensation that like, ooh, I better go to the bathroom, like right now. And then you cognitively open up that external urethral sphincter, and then the detrusor muscle will actually contract. So muscles can only get shorter or relax, and so the detrusor muscle will get shorter. And when it does that, because it's circular, the circle that is your bladder gets smaller. And when it gets smaller, it pushes that fluid out. The external urethral sphincter is already relaxed, and so urine flows out, and that's pretty much it. That's all there is to it. Pretty straightforward. Oops, sorry. Give me a thumbs up when you've written what you want to write, and I'll click on, but I don't want to click on too quickly. Got about 2 or 3 thumbs up, so I'm going to wait just a minute. More thumbs up. Cool. All right. Well, let's talk diseases, the kind of sad but also amazing process of dialysis, and we're done with the chapter. So that's pretty cool. So let's do that. So diseases and clinical applications for urinary systems. We've already talked a little bit about UTIs, which is urinary tract infection, most oftentimes bacterial. Fungi don't do well with acid, so they really don't do well with urinary tracts. Bacteria can make it work, however. So let's talk with anuria. Let's talk about, sorry. A is without, urea is urine. And so this word literally means without urine. Obviously that should be concerning to you. Even, the kind of average Joe would be like, you stopped peeing? That's not great. So that's the total absence of urine. If you stop peeing, that's obviously a problem. There could be a couple of things causing this. Worst case scenario, you could be in kidney failure, which would lead to the dialysis road we're about to talk about. That would be bad. Your kidneys are doing a huge job. You can get by with one, but if you're not creating any urine and both of your kidneys have failed, that must be addressed like right now, because you're going to have to get on dialysis, you're going to have to get a kidney transplant, you're going to accumulate a lot of bad things in your blood that your kidneys are not filtering out. And so kidneys have to be doing their job. It could also be due to an obstruction. We watched that video, the UPJ obstruction, pardon me, where the person had these really large kidney stones, renal calculi that they were taking out. If a kidney stone is large enough, to block that, essentially the outlet to that renal pelvis, where it enters the ureter, like you could stop the flow of urine, like right at the end of the kidney, right at the renal hilus. And that can't feel good. I don't know, never had any kidney stones, fingers crossed. Yes. But there's no way that can feel good. So that stone large enough could completely stop the flow of urine. That would be bad. Here's renal calculi. We've already done a video on this because you guys had questions about it right off the bat, which were kidney stones from eating these, salts in our diet and being dehydrated and things like that. And those crystals can get accumulated into bigger salts, and the salts can plug the tubes. And then there's this whole process of, is it surgery or do you like break it apart with sound waves? And I don't really know how that all works, but there is an issue with that. Super weird, unrelated note. Just chalk it up to the things Mr. Stecker will never understand. You can get uric acid crystals places other than your kidneys. And I'm not a doctor, so like don't quote me on this, but I'm pretty sure, like 99% sure off the top of my head, that uric acid crystals can accumulate in your joints, like your knuckles and your toes and your ankles. And I think it's called gout. And it like hurts the person to move. And it's so weird because like, how does uric acid, right? This solid that should be in your urine, like getting in your knuckles and your ankle? I don't know. It's weird, but that's like gout, I think. Again, don't quote me on it. Run it through Google, but I'm pretty sure you can get uric acid crystals there, which is weird. Anyways, diuresis is too much pee. So increased production of urine. We know the word diuretic from like caffeine's a diuretic and soda pop's a diuretic. And so diuresis is increasing the production of urine from something that's in your diet or something like that. And then there's uremia, and uremia is, I've got chat box messages. I'm sorry, give me one quick second. Pain and inflammation occur when too much uric acid crystallizes and deposits in the joints, from Google. Yay, I'm not crazy. Thanks, I appreciate that. So it must be a South Dakota thing. I've worked with 2 guys who had gout, and they just mentioned how bad it hurt, like to walk and stuff. And I was like, uric acid in your ankle? Okay, so I don't know what that means. I'm just gonna drink a lot of water and hope it works out. So uremia is way too much urea in your blood. It's not being effectively, transported out of your bloodstream, and so that's an indicator that you could be looking at kidneys not functioning well, or kidneys even failing. And so I'm sure there's many more, but there's a few diseases to kind of get you thinking about. Basically, there's homeostasis. Urinating too much is bad. Not urinating at all is bad. Not getting rid of your urea is bad. These kinds of things. So it's a pretty finely tuned system, as you might imagine. So let's talk dialysis. This is a very sad thing, but is incredible when you think about it, that we can even do this. Dialysis is, from my basic understanding, is like a fake kidney. It's really cool. If you went into kidney failure, like both your kidneys shut down, you have a few options on the table. Option one is a kidney transplant. You can live with one. And so knowing that if you had a really, really cool friend or family member who had blood type similarities and were a match for a donor who really, really liked you, they could go and give you a kidney and you would be healthy and they would be healthy and life would go on. The other option would be to slowly accumulate toxins in your blood until you died. And the other option is this little miracle called dialysis. And dialysis is basically a fake kidney for you. I don't know who or what team people came up with this, but it is really cool. Kidney failure, like when they shut down, they shut down. It's not like, oh, I got a scratch, but in a bit it will heal and I'll be better. It's more like, this is the end of the road, kind sir. So dialysis can be for the rest of your life or until a kidney transplant is available. And there's multiple types of dialysis. I don't claim to be an expert, but basically I've got a video for you. And there's a solution called dialysate. And the dialysate will essentially work like a kidney to pull the bad stuff out of your blood and keep the good stuff in your blood. And so it's like a liquid filter, like a machine, like an external machine. And I'm sure there's been advancements in this that I'm not aware of, but essentially your doctor will create a fistula, which is really cool because they will take like an artery and a vein together and they will cut them and sew them together. So they have this big port available and you will go in, which you're not going to be very happy about, but it'll keep you alive. My understanding is basically you stay pretty dehydrated all the time, which is inconvenient. But every 2 or 3 days of your life, you will go in. And that includes like if you're traveling a vacation, making a trip, you will call ahead to dialysis centers and make appointments along your trip. And you will stop and you will go in and they will plug your fistula into this machine and it will take your blood out slowly, pump your blood through this dialysate. The dialysate will take away excess ions, will take away urea, will take away uric acid, will give you back the water and put it back into your fistula, which is like an artery and a vein combined. And so it's a machine kidney. And you sit there. I don't know how long it takes, an hour or something, and you just sit there and let it clean your blood. And then they unplug you and you go about your day. It's so cool. And it keeps you alive. And hopefully you get a kidney transplant sometime because every 3 days, I think that would be just so boring. But that's a fistula. Your average life expectancy is 5 to 10 years. But again, that's old information. And there's new progress every day, including an artificial one that I think they're working on or already using. So who knows? The other option is you can actually do dialysis in your abdomen by pumping the solution inside, which is super cool. And I don't really claim to understand, but I'd love to show you a video. We got 4 minutes, which is about how long the video is. So I'm gonna show you the video and that's the end of our notes. So 1 second, I'll pull that up for you. Here we go, that's better. Sample use only.
Your doctor may recommend dialysis, a procedure that removes waste products from your blood if your kidneys are not functioning properly. Healthy kidneys filter out waste, excess fluid, and electrolytes like potassium and sodium from the blood. These waste products exit the body through the urethra in the form of urine. If you have kidney disease, your kidneys gradually lose function, leading to an accumulation of harmful waste and excess fluid in your body, increased blood pressure, and bone or blood problems. Dialysis can also be done to treat acute kidney failure, which occurs when your kidneys stop working suddenly, or to remove drugs or poisons from your body. In one type of dialysis, called hemodialysis, your doctor will use a machine called a dialyzer to clean your blood outside your body. Some weeks or months before you begin hemodialysis, your doctor will prepare a vascular access site on your body. Your doctor will create either an arteriovenous graft or an arteriovenous fistula to access your bloodstream. To begin, he or she will numb the area with local anesthesia. To construct an arteriovenous graft, your surgeon will make a small incision in your forearm and insert a soft plastic tube called a graft to connect an artery to a vein. To create an arteriovenous fistula, your surgeon will make a small incision in your skin and connect an artery with a vein to make a larger vessel called a fistula. Once your vascular access site has healed, your doctor can start hemodialysis. To begin, your dialysis nurse will insert 2 needles into your AV fistula or graft. Once the circuit is set up, your blood will flow slowly out of your body and through the dialyzer. Inside the dialyzer, your blood will encounter filtering fibers and an absorbent cleaning solution called dialysate. The fibers will remove waste and excess fluids and electrolytes from your blood. Your cleaned blood will emerge from the dialyzer and continue through the tubing back into your body through the second needle at your access site. When your hemodialysis session is complete, the needles and tubing are removed, and you can go home.
That's good.
In another type of dialysis, your doctor will use the membranes lining your abdomen, called the peritoneum, to clean your blood without removing it from your body. Before you begin peritoneal dialysis, you will have an operation to implant a soft tube called a catheter. Your surgeon will insert the catheter near your belly button, creating a port through which the dialysate will enter and leave your abdomen. Each peritoneal dialysis session is called an exchange. First, you will use your catheter to fill your abdomen with dialysate for a period of time determined by your doctor. Through the peritoneal membrane, waste products and extra fluid are continuously drawn out of your blood into the dialysate. Along with the waste materials it absorbed, the dialysate will drain out of your abdomen into a disposable collection bag during your exchange.
All right, that's it. Isn't that cool? I don't know. I know it's just an animation, but does that make anybody else's stomach feel weird when they see the little yellow sticky thing and say, "There's a soft, flexible port"? I'm like, I don't like that. That makes me feel weird on my insides. Anyways, so go ahead.
I didn't think they would use the fistula like in an arm or something. I was expecting to have more in the kidney area.
You would think they would use a fistula where now, John?
Like put it like on your back, kind of like the kidney area, instead of like in your arm.
Oh, well, I think it's the arteries and veins on your arm are very readily accessible and pretty close to the surface. And I think that's probably why that'd be my guess as to why they would do it there. And your back, you're always laying on it and that kind of stuff. So I don't know with how many large arteries and veins are that close to the surface, but you would be closer to the kidneys, and you'd also have a lot less sensitivity on your back than you would on your arm. So certainly a thought. So we're a little over our time, but do you have any questions about kidney dialysis, schedule for the week, anything at all for me before we call it? Pretty quiet on that end. Okay. You guys feel good? You know what you're doing this week? Everybody feels comfortable with what the plan is and everything like that? Okay, cool. So I will not see you again until Thursday. All right? So Thursday at 9 a.m., we'll be back. Review tomorrow, test Wednesday, back Thursday at 9. And